Our first resource person for the evening is Dr. Melanie Veerasurya, who works as GP Principal since 2014 and as a member of Penge Primary Care Network since 2019 in Bromley, England. She was the president of the Sri Lanka Medical and Dental Association from 2016 to 2017. She graduated from St. Mary's Hospital Medical School at Imperial College London with an MBBS in 2001. After completing vocational training and obtaining the JCPTGP in 2005, she worked as GP principal in Croydon from 2005 to 2008 and as GP in Hounslow from 2009 to 2014. She obtained the DFSRH in 2008. She also obtained the BSc in molecular biology in London in 1994. Dr. Melanie has worked as a clinical epidemiologist in HIV/AIDS at the Health Protection Agency UK from 1990 to 94 and presented and contributed to publications on patterns of HIV infection in children, adolescents, and young adults, and unlinked anonymous antenatal testing and clinical manifestations of HIV and AIDS.
Yeah. Thank you very much for that kind introduction, and thank you to the President and the Council and the Organizing Committee for inviting me to present at this prestigious event. I'm here to present to you on COVID-19 management now and tomorrow, a UK GP perspective. I'm a single-handed general practitioner looking after a patient population of 3,000 in an area called Annerley in Bromley. And Bromley has a population of 330,000 patients. And I'm also a member of the primary care network for Bromley in the area of Penge, looking after over 35,000 patients. So I'd like to give you a summary of my presentation with the introduction and background regarding COVID assessment clinics, primary and secondary integration, changes in practice since COVID-19, long COVID, and lessons learned with some reflections. So COVID-19 needs no introduction. We are learning to live with it, we are learning to work with it, and we are learning from it. The role of the GP in the UK is that the patients, the first port of call is the GP. And during the COVID-19 pandemic, we had to adapt quickly to deal with more patients than normally call. And we had to continue still with the patient-centered care while working with the changing guidelines almost on a daily basis. The first case in the UK was diagnosed in January 2020. The numbers rose steadily and the hospitals were unable to cope with the patient demands, presenting to A&E departments with COVID symptoms. So the government, the NHS, formed the COVID assessment clinics. This was set up to reduce the burden on the NHS hospitals. And this was manned by GPs, nurses, and pharmacists. And GPs would assess the severity of the symptoms that patients presented. And so to man this service, there were thousands of doctors recruited, including retired doctors, and they had to undergo rigorous training, and they had to follow COVID protocols and keep up to date with changes in management. So the symptomatic patients were encouraged to call the NHS 111, which is a call center. And they would triage the call according to the protocols. And if they suspected COVID-19, they would instigate an online PCR and the patient will be directed to the appropriate point in the pathway. So this is a busy slide. This is the COVID assessment pathway. I will take you through piecemeal. And so as I said initially, they would be triaged by NHS 111 and then further advised to pass on to the COVID assessment clinic, and a member of staff there would further assess the patient and categorize to severe symptoms. In that case, they would be advised to go to hospital or be admitted, and the non-severe symptoms, which is then again divided into the mild and low risk, who can be managed at home with safety netting, and the rest would be further assessed face-to-face with infection prevention control measures in place to mild, moderate, and severe according to their oxygen saturation levels. Again, if the oxygen levels were less than 92, they'd be considered as severe and again advised hospital care, and the mild to moderate would be further assessed to consider whether they were eligible for oximetry at home or COVID-19 therapeutics. Then assessing for oximetry at home, well, if the patient was at high risk, such as if they were 65 or over, they had comorbidities, they are not double vaccinated, and the clinician was concerned, or they were pregnant or disabled, they would be considered for this, and the oximetry at home is instigated. If they were not, then they would be kept at home safe, and both parties would be assessed for therapeutics in the community. So in order to be eligible for therapeutics in the community, they would have had to have a positive PCR test within 5 days, and they would have to belong to a high risk category, which I will go to the next slide, but and they would not require hospitalization or oxygen therapy. They shouldn't be under 12, shouldn't have a weight less than 40, or not being contacted by the COVID medicine delivery unit directly within the last 24 hours. So going to the criteria, that they should be eligible to, there are sort of conditions like Downs, sickle cell, patients with solid cancer, hematological malignancy, renal disease, and they are described in this way in a more detail. And then also patients with liver disease, immune-mediated inflammatory diseases, primary immune deficiencies, HIV/AIDS, solid organ transplant recipients, and neurological conditions, and the descriptions are given on this slide. So, those who were eligible to be referred to the COVID medicine delivery unit, they would be considered to be treated with either the neutralizing mononuclear antibodies, which is given intravenously, or the antivirals, such as the molnupiravir or remdesivir, which is given orally. If they are contraindicated to get the NMABs or difficult to administrate. So those who fulfilled all the criteria, they would be contacted automatically. Sorry, I'm trying to get the contacted automatically by the specialist clinic, because these high-risk patients would anyway be under specialist clinics and be contacted automatically to consider for the NMAB or antiviral therapy. And if they were not already contacted by the COVID medicine delivery unit, the patient can get in touch with their GPs in hours, or NHS 111 out of hours, who can then refer the patient directly to the community medicine delivery unit. Then another important thing that took place during the or taking part during the COVID-19 pandemic is the integration of primary secondary care, where the secondary care would produce the necessary documentation and guide the primary care towards to how to deal with the patients with the chronic conditions and COVID-19. For example, if the such as patients with conditions like rheumatoid arthritis or diabetes, the teams will be alerted and their medications would be monitored and changed accordingly. And a particular concern was children with COVID-19. We were alerted to look for flu-like symptoms and skin changes, which may indicate the possible diagnosis of pediatric inflammatory multisystem syndrome, which is a rare but serious condition, and also the pregnant patients. The necessary teams would be alerted. Again, this is a community decision support tool for the pregnant ladies who are confirmed with confirmed or suspected COVID, which I'm not going to go through now. I think the most important thing was the changes in practice since COVID-19. Main change being in the consulting methods. The remote consulting became the mainstay, obviously, to reduce the COVID-19 transmission. We used email consults, the telephone initially, and then managed either by continuing with the telephone or changing to either video or face-to-face. The problem with this was if there was a non-working telephone or if they had hearing impairment, English was not the first language, or they were elderly, or they were mental health patients, which therefore had to be converted to face-to-face. So the face-to-face patients needed to complete a new onset COVID symptoms questionnaire prior to their appointment. With the face-to-face appointments there was a great reluctance of patients to come forward to the GP surgeries for their annual reviews of chronic disease management, and also for their screening, such as cervical screening, and then to other centers for things like the breast screening. The other important thing was the childhood immunization uptake, which reduced, especially MMR vaccine, which is obviously important as due to possible measles outbreaks, and also the possibility of the complications of measles with immunosuppression, therefore making them susceptible to opportunistic infections. However, because of the enhanced infection prevention control measures, national lockdowns, and reduced travel, there were fewer cases of measles. Another problem or change that happened was with investigations such as phlebotomy and X-rays, where patients were able to walk into these for these investigations, had to have an appointment to do so. The problem was booking the appointments, issues with the booking the appointments, waiting times for the appointments because they were increased due to increased infection prevention control measures and fewer appointments, and difficulties for vulnerable patients to get to places for investigations, as they used to be able to go when they felt well. Another issue was with the hospital appointments, because staff were redeployed to COVID wards to manage the demand of COVID patients. Urgent referrals could have taken up to 6 months, or routine referrals up to 12 months, but the cancer referrals are managed within 2 weeks. An important aspect of COVID-19 is obviously infection prevention control. So in GP practices, patients filled in the COVID-19 questionnaires and temperatures were checked prior to their face-to-face appointments. They had to wear their face masks, sanitize their hands, and the chairs were placed with social distancing and wiped after each patient. And clinicians going to have face-to-face appointment needed to wear their PPE. GP practice staff needed to wear face masks at all times, maintain the social distancing in the workplace, and also do their lateral flow test at least twice a week to exclude COVID infection and minimize transmission. So this is a schematic of how to end self-isolation, which is a 10-day self-isolation rule, and ending self-isolation in 5 days with negative lateral flow tests. So obviously an important aspect was the dissemination of vaccinations, which started in January 2021 in the UK, guided by the Joint Committee on Vaccination and Immunisation, and advised on priority groups for COVID-19 vaccination. The rationale being that the age-based prioritization for the COVID-19 vaccine included around 99% of people at risk of dying from the disease. So this sort of gives the age breakdown cohorts, starting from in vaccinating the care home and the older adults and their carers first, then going on to the those over the age of 80 and frontline health and social care workers. We have actually vaccinated up until 12 years of age. So the vaccinations took place in 3 settings: hospital, community, and mass vaccination centers. But the majority was done by the community vaccination centers via the primary care networks, because primary care networks looked after patients ranging from 30,000 to 100,000, and therefore gave a good coverage. They were supported by the individual GP clinics and also by vaccinating the housebound patients via roving clinics. All staff who were involved in vaccinating people had to undergo specific training, which included training on anaphylaxis, training for the different types of vaccinations, and they had to be up to date with the standing operating procedures, which included the correct storage of vaccines, maintaining the cold chain when the vaccines had to be transported from one to the other clinic. And the vaccinators were also encouraged to report significant events and adverse events from vaccinations. For example, there was a significant event in the case. There was a female under 18 who was vaccinated with AstraZeneca, but the age wasn't checked at the time with the type of vaccination, so a lesson was learned that age had to be checked against the vaccine both at the reception level and at the vaccinator level. So with regards to vaccinations in the satellite clinics, which are the GP clinics, and the roving clinics, which are the housebound patients' vaccinations, had to also go through an extra additional pathway whereby they had to have authority from the medicines managements to undergo the vaccination schedules, because they needed to because they needed to undertake special measures when picking vaccine vials from the main clinic and transporting to the satellite clinics or to the housebounds, maintaining cold chain for the efficacy of the vaccine. So the other important thing was long COVID, which is classified as patients who have a sequelae of COVID symptoms 3 months after their initial infection. And these patients could be referred to the long COVID clinics, and which were established to address the issues of long COVID. The main symptoms that persisted beyond the 3 months were the shortness of breath, chest pains, brain fog, joint and muscle pain, and excessive tiredness. So, what are the lessons that we learned? What went well? So, we believe the COVID assessment clinics and hubs that were started at the beginning of the pandemic relieved the pressures in the hospitals. The patients had a choice of consultation. Therefore, they were able to get through to their GPs easily. And there was improved access to prescriptions for the patients, because the prescriptions were able to be sent electronically to any pharmacy that the patient requested them to. Then there was also enhanced infection prevention control measures, which we are still adhering to, and which is helping to keep the infection and transmission under control. And the primary care network vaccination hubs, supported by the GP satellite clinics, and we actually won a performance on that in vaccine delivery. So what didn't go well? The patients being reluctant to present to GP practices, therefore they delayed, and therefore resulting in delayed or misdiagnoses. Their reluctance to present for screening, and obviously worried about the COVID-19 infection, and reduced childhood vaccine uptake, and a main aspect in the UK was the vaccine hesitancy among the Black and ethnic minority groups, who were also likely to have chronic conditions and complications of COVID-19 infection. And also the delays in the hospital appointments, resulting in increasing patient anxiety and therefore leading to increased patient complaints. So some reflections. So all the knowledge and experience we gained in the first wave, we managed to use in the second wave. And we are still learning about COVID-19 sequelae and complications. So we don't know where the next threat to our health system will come from. But I'm sure the lessons we learned from this pandemic will undoubtedly be helpful for the next. So will the threats come from vaccine hesitancy, antimicrobial resistance, or as a result of returning to international travel or social mixing? We are likely to feel the sequelae of COVID-19 for years to come. But having good infection prevention control measures, surveillance programs, and address the healthcare inequalities should be the mainstay of our healthcare reforms. Thank you for your attention.
Thank you, Dr. Melanie. If you could stay with us for a little longer, we have some questions for you at the end of the second session.
Yes, the next presentation will be on a global update and the perspective under the heading of COVID-19 management now and tomorrow. Now, I'm somewhat embarrassed to introduce the next speaker because, in fact, he is better known than I am in Sri Lanka, certainly, and definitely abroad. But nevertheless, I will make a brief attempt at trying to introduce him to him, someone whom you know. Professor Suranjit Senaratne is an international expert in immunodeficiency, autoimmune, allergic, mast cell disorders, and immunogenetics. He has currently at the Institute of Immunity and Transplantation, Royal Free Hospital, University College, London, and Health Service Laboratories, London, UK. He completed his basic medical degree at the Faculty of Medicine, University of Colombo, with first-class honours, 8 distinctions and 10 gold medals, and was placed first in his year. He completed his MD in internal medicine and trained in clinical immunology and allergy at the John Radcliffe Hospital in Oxford. He is a Doctor of Philosophy in Molecular Medicine. He is a Fellow of the Royal College of Physicians, Royal College of Pathologists, Royal Society of Medicine, and Ceylon College of Physicians. He is also an Honorary Fellow of the College of General Practitioners of Sri Lanka. Professor Suranjit Seneviratne, ladies and gentlemen.
Thank you very much, sir, and thank you very much for the invitation from the President, Dr. Matthew, and the Council to give this talk. I hope you can hear me and see the slides correctly. So what I'll do here is give you an overview and a global update and perspective on COVID management now and for the future. We have been 2.5 years into this pandemic, and so many things have changed as time has gone by. And even in the last month, there has been so many new bits of information that have come out with regards to COVID. So the summary of the talk I will do today would consist of a helicopter view, a quick overview of COVID till now, aspects regarding Omicron, immune response, 4th dose of vaccine, antiviral agents, pan-COVID and Omicron-specific vaccines, vaccines in children, and then end up with long COVID. Now, we know the virus, the spike protein. Why did I put this figure? Because importantly, we have targeted spike protein, but this virus has many other proteins. And it's important to know the vaccine response. The immune response is against a whole range of proteins, which I will talk later on. And secondly, the vaccines, which are initially against spike proteins, are being updated to include the other proteins and to get a response against other proteins too. Many, many million cases of COVID have occurred in the world, 531 million or so, with about 6.3 million deaths. And these were the breakdown in the different countries, including Sri Lanka. So it's a big problem. Vaccination has come out together with other measures, social distancing. Many vaccines have been approved. Some vaccines have failed, and we have to remember that. They were evaluated. If they did not meet expectations, they failed, and certain vaccines were approved. We know this slide. On this slide many, many times before, I've showed this slide, the number of vaccines that were available that are being used today, including the viral vector vaccines, the mRNA vaccines, and the subunit vaccines together with the kill vaccines. So this is the sort of characteristics of the different vaccines that are being used today. Now, if we look at this slide, if this is a sort of bird's eye view from May last year, 2021. And you can see that certain countries were rolling out vaccination very rapidly. Certain countries were lagging behind, including India. You could see that India was lagging behind. However, in August that year, things improved in India. But at the current moment, still countries in Africa, such as Nigeria, are really lagging behind with regards to vaccine sort of distribution and vaccine uptake. So there is an unequal distribution of vaccines, and this is very important when we think of getting a pandemic under control around the globe, because if new variants come up, that is going to cause issues around the world to many, many places that have been vaccinated too. So this schematic shows just an overview of COVID, just to put in place where, if you look at this, you can see that as the viral load increases, the immune response comes into play, and then the viral load decreases. The important role is to prevent that patient going into hospital and getting complications. And that's where primary care has a very, very critical role early on to ensure that the person is identified properly, the current treatments are started, and the person is prevented from going into hospital, together with the patients getting vaccinations and preventing the disease process and infection and preventing the complications occurring in the disease. So primary care has an important critical role to play. So next we go on to Omicron, which was something that came up in November 2021. It hit the world. We became aware of this, and it has taken over the world. The number of the cases of Omicron has rapidly increased and replaced Delta, which was there previously. So giving you some background information, you have the variants of concern, Alpha, Beta, Gamma, Delta, and Omicron, and the variants of interest. Some of these were originally released, now they have changed. This is WHO nomenclature. And what do we take into account with regards to these variants? That is the ability to spread, transmission, severity of the disease, vaccine response, and treatment response, and diagnostic tests. That is what is important, the 5 factors that we take into account with regards to considering if a variant is important and if it's a variant of concern. We have written, together with many others, several articles about the different variants. This is an article on the Delta variant, and then a whole range of articles on Omicron variant. And the risk of infection, risk of hospitalization was low with regards to Omicron. And this has been taking over the world in recent months. This schematic shows the distribution of the different variants as months went by. And now you would know that most of it, Delta has been replaced in most countries, many countries, and Omicron is the main variant that has been transmitted in different parts of the world. But we have to remember that there is BA1, the original variant, and there are many subvariants. That is BA2, BA3, BA4, and BA5. And in recent months, BA4 and BA5 has been taken over in certain countries like South Africa and increasing. And that is important when it comes to India, Sri Lanka, etc., because especially in a place like India, where the booster vaccines have been delayed and there's a big delay in between the second and the third vaccine, we have to take into account, because BA4 and BA5, which are not as responsive to vaccines coming there, that can cause an issue. And in Sri Lanka, we have to be very grateful that the vaccine process has moved forward and many people have also received the third dose, and they are considering the next dose has also been considered. So those are 2 important factors to remember with regards to Omicron and the BA4, BA5 subvariant that is seen in the world in recent time. This is the picture from South Africa, and you can see that BA4 and BA5 is increasing as it goes to the right hand down the slide. You can see that BA4 and BA5 is increasing in the recent months. And yesterday, Portugal again was reporting an uptick in the number of BA4 and BA5. So that is a subvariant of Omicron. Next, we come on to the immune response. Just to touch the immune response, because I just want to go into vaccine aspects and the sort of pan-corona vaccine. And if we look at the immune response, I've used this slide many times before, telling you that there are antibody responses and white cell responses, that is lymphocyte responses, that are important with regards to an immune response. That is antibodies, CD4 cells, and CD8 cells. We cannot look at only antibodies and say that that is sufficient immune response. You have a cellular response that we have to take into account in many people. The immune response resulted in increase. Certain cells were increased, like neutrophils, certain cells were reduced, platelets, changes, cytokines, hypercytokinemia, and the original treatments that we gave outside hospital and inside hospital once they got into hospital, was based on the pathophysiological mechanisms and the pathoimmunological mechanism that we worked out early in the pandemic. So you have antibodies, IgM antibodies, IgG antibodies, CD4 cells, CD8 cells coming into at different time periods. And that is why, rather than waiting for the person to get the condition and then develop these immune responses, we give vaccines, safe vaccines, so that we can get these immune responses in place before the person gets the infection. Now, it's important to remember that in addition to the viro, that is the different proteins and the genes that are found in the virus, you have the immunome, that is the different parts of the virus that make certain immune responses. There is a CD4 antigen, there are CD8 antigens, and there are antibody. These are important because spike protein was very immunogenic from an antibody response, but some of the internal proteins are important for the cellular responses, or more important, the cellular response. That is why the newer vaccine constructs are trying to integrate these, trying to join these, trying to bring these in to improve the vaccines. So the current vaccines were originally targeted against spike, but newer vaccines are developing against the other immunogens, and this is the SARS-CoV-2 immunogen. We have to remember that age is an important factor. Immune responses wane off with increased age. Older person, immune response is not good. Same thing with COVID-19, with SARS-CoV-2, and therefore this is a population that should be looked after. They should be targeted. They should be looked after. They should get their vaccines early, because with age the immune response is poor, and you want to have a better response if you meet the virus as part of the day-to-day activity. So this comes under the 4-dose COVID vaccine, which people are talking about in the world at the current moment. Last year, the 3rd dose of the COVID vaccine was recommended somewhere in September last year, and then we found that it was a safe vaccine. It was especially important when it came to Omicron, because the 3rd dose, many countries around the world rushed to give the 3rd dose because they found 2 vaccines alone was not sufficient against Omicron. In the cancer patient, I told the older patients, the cancer patients were important because that was one group that was at high risk of getting severe COVID and dying. And therefore, this was a group that was targeted with regards to the COVID vaccines to ensure that they received the COVID vaccines early, and 3 doses were equivalent to 2 doses in a healthy person. That is, the 3 doses, cancer patients were given 3 doses very early, while other healthy people were given 2 doses and then get a booster. Now, there are studies with regards to the booster. This was the early Israel study which showed that with the 3rd dose of the vaccine, you found that the response to Omicron, antibody response increased, but then there was waning. And when you gave the 4th dose, there was an increase in antibody level to the levels that were seen when the 3rd dose was given. That was after some time period. So that is why it was recommended that the 4th dose be given to high-risk populations and those over the age of 75. And that is what has been done in the UK in spring. But most likely in the fall or in autumn, you'll find that a wider group of people are going to get this 4th dose of vaccine. Now, this was again especially important when it came to Omicron. And we know the subvariants of Omicron, or subvariants have been circulating BA4 and BA5, especially in that context. A 4th dose would need to be targeted to specific populations, at least initially, and then depending on the data, other groups could be included in that population. So the important thing is targeting the proper groups and do it early. When it comes to the next phase would be, we spoke about the 4th dose of COVID vaccine, and also last week, I have to update you that the COV-BOOST study came and showed that it was safe, the 4th dose, and it increased the antibody response and the cellular response even more than the 3rd dose of vaccine. So that was an important finding that came up from the COV-BOOST study. The previous study that I showed was the Israeli study. When it comes to antiviral agents, we have written quite a lot about this aspect, and this is an article that you can read, the oral antiviral agents, molnupiravir and Paxlovid. And the important thing is to compare these two and give it to the correct group of patients early and PCR positive patients early in the course when they are symptomatic. That's a very important group of patients. In this slide, I've compared the two different antiviral agents that we use. One agent is used over 12, the other one is over 18. There are different mechanisms of action. One integrates into viral DNA, RNA, and the other it integrates a viral RNA, and the other one neutralizes an enzyme that is important in viral replication. And the different, it's still a bit too costly for many parts of the world, but as months go by, the cost will reduce as patent goes out, and therefore this would be an important step with regards to targeting especially the high-risk population. There are certain groups that this drug should be, use of this drug in those populations would help reduce the hospitalization and severe disease in those population groups. Next, we come on to other developments that are occurring in COVID in recent weeks or recent months. That's the pan-coronavirus vaccine and the Omicron-specific vaccine. Now, we know in June that important announcement, especially with regards to Omicron-specific vaccines, are to be decided by the FDA committees. And certain studies have been done, which I won't go into great detail now, but at the current time, we are still uncertain whether we should go ahead with for the overall population, the 4th dose with the standard vaccine or whether it's Omicron vaccine. The data has not been extremely sort of one-directional, and this plan and this decision will be made by the FDA in the next few days towards the end of June. So that's an important decision to be made with regards to Omicron-specific vaccines, as still some data from Moderna are expected in the next 2 weeks or so. Children are the other group that will be that some important decisions will be made, especially the very young children, because which I will come into in the next few slides. So when it comes to pan-coronavirus vaccines, that is, in addition to SARS-CoV-2, can we target with one vaccine other coronaviruses also? Much work is being done at the moment. Some are preclinical work, some are clinical work, targeting these different groups of coronaviruses. And that would be an important advance, which I should be able to update you in the next 4 months or so with regards to the pan-coronavirus vaccine. So you have the Omicron-specific vaccine, the original vaccine, and the pan-coronavirus vaccine, which will be taken off as we get more data and clinical utility of those different vaccines. Next, we come on to COVID vaccines in children, another important group, because at the moment we have vaccines up to the age of 5. And there has been discussion, much discussion in the world. What about the children from 6 months to 5 years? How do we protect them, and how do we protect infection and severe disease in a small group of children in that age group? So again, we have written quite a bit on COVID-19 vaccines in children, but just a take-home message that I'll give you with regards to vaccination in the UK, COVID vaccines in the UK for children between the age of 5 to 11 years. It's 2 doses of vaccine, 12 weeks apart, unless they're high risk, when it will be given 8 weeks apart. And it's 10 micrograms. It's orange cap vial, 10 micrograms. It's 1/3 the dose given to older children and adults. We're talking about the Pfizer vaccine from 12 to 15 years of age. It is 2 doses, 12 weeks apart. High-risk children, 8 weeks apart. It's 30 micrograms. And the booster again is targeted for high-risk children, where you give it booster 12 weeks. That should be 12 weeks, not 2 weeks. Sorry, at 12 weeks after the second dose. And this is with regards to the regards to the Pfizer vaccine. That is scheduled, because the Pfizer vaccine is one that is used in the UK. So again, as I mentioned, in June, mid-June, there will be quite a lot of discussion about releasing vaccines for the youngest children, 6 months to 5 years. The studies have come out. The Pfizer vaccine was found to have an efficacy of 80%, very recently released, while the Moderna vaccine was not as effective. And it is most likely that the Pfizer vaccine given in 3 doses, very much lower dose being given compared to older children, would be approved for use in the youngest children. And that is an important discussion that is being held at the moment, and the information will be released very, very soon. Finally, I'll come on to long COVID, which is an important topic with regards to many of our practices, especially primary care, because the patients present initially to primary care, and that is so important to be able to identify this group of patients and direct them correctly and treat them correctly. Again, quite a bit have been written about long COVID. This was an article some time ago that we wrote about long COVID. The important symptoms to remember is fatigue, extremely important. Lots of patients, just after COVID, they can have fatigue, but this persists for more than 3 months. Shortness of breath, a whole range of symptoms that I've indicated here, and the different sort of prevalence of those symptoms of fatigue and shortness of breath are 2 important symptoms, including brain fog. Different mechanisms have been considered with regards to why people get long COVID. Some of the mechanisms, which I won't go into detail, have been put in here, such as autoantibody responses, immune dysregulation, viral persistence, etc. And these are some important factors that scientists around the world are working, because if we know the pathogenesis, then we can target them properly. Because at the moment, the pathogenesis is still a bit unclear. So this is again a distribution of the different pathogenic mechanisms based on the symptom. That can be autoantibody response, viral persistence, immune dysregulation, cytokine responses, etc. And the treatment that we're targeting could be more selective and more targeted so that we can appropriately manage these different symptoms in the patient, because it is a big problem in our clinics at the moment. Cardiovascular manifestation, extremely important. COVID, SARS-CoV-2 causes endothelial dysregulation, increased risk of clotting, microthrombi, and other clots. Cardiovascular events, including inflammation in the heart, can occur, and therefore cardiovascular risk is increased post-COVID. That is important to remember. Cardiovascular and neurological risk, especially cardiovascular, the death rate and the risk after cardiovascular death rate is higher after COVID. And this must be looked at and managed appropriately, because otherwise you'll find quite a lot of morbidity occurring after the person has COVID. We too have looked at this in Sri Lanka and found that post-COVID cardiovascular is an issue that does need some careful sort of monitoring and proper management to bring the morbidity and mortality under control. So where does this fit? You have the cardiovascular and the respiratory teams, which will do their tests. You have the nephrology and the hematology teams, which will do their appropriate management together with the rheumatology. And centrally, you have primary care, because the primary care physician is the person who is in direct, immediate contact with the patient. And that is so important with regards to preventing COVID and picking up long COVID and referring them or managing them themselves and referring them to appropriate teams for proper management. So with regards to final message is about vaccination and long COVID. Recent studies have come out finding that the trajectory of long COVID and the problems with long COVID appear to be reduced with vaccination. So that's another reason for vaccinating patients with the COVID vaccine, because the risk you can get long COVID with mild or moderate COVID. So you can reduce the risk and reduce the ill effects of long COVID with vaccination. These are early studies, but more information should be coming up. More definitive studies should be coming up. So finally, this is a summary of the things I spoke with regards to COVID. You can see the amount of new things that have been spoken about in recent years. It was a helicopter view of COVID until now over the past 30 months. Omicron, BA4, BA5, immune response, and telling you that there are cellular responses in addition to antibody response, and those are important things to target in our future vaccines the 4th dose of COVID vaccines and the 2 studies, the Israeli study and the COV-BOOST study. Antiviral agents, extremely important. Cost does need to come down. It's important in a specific targeted group, like the 4th COVID vaccine, important specific targeted group. Then we went on to the pan-COVID vaccines and the Omicron-specific vaccine, which again, some information will come out in the next 3 months. Children, youngest children the vaccine should be approved for the youngest children. And finally, an important condition that we have to remember, long COVID and cardiovascular morbidity and mortality post-COVID, that has to be remembered. And it appears that vaccination is also having a positive impact on reducing the effects of long COVID. Thank you very much.
Thank you very much, Professor Suranjit. Now the 2 topics are open for discussion. If there are any questions, please raise your hand and the mic will be brought to you so that we can relay the question directly to the authors.
Hi, Suranjit. Just a question. As you know, we senior GPs, we get bombarded with questions from our public. So there are a lot of people asking whether they have to take the 4th vaccine and when do we get it. So there are a lot of older people who with comorbidities wanting it, but is it sort of finally decided that they should get it, or do you recommend it 100%?
Thank you very much, sir, for that question. Very appropriate, very important question. So we knew 2 vaccines from the beginning reduced hospitalization, death, and complications. 2 vaccines were there. Then Omicron came along in November 2021. And then we found that Omicron was escaping. It was a mild infection, but it was escaping. We know the effects even that mild infections can cause in people, neurological effects, cardiovascular effects. So Omicron came and we found that you did need a 3rd dose of vaccine. And that was rolled out around the world. First, it was 6 months after the 2nd dose, and then it was 3 months, and now it was given 3 months after the 2nd dose. Then it came to the 4th dose of vaccine. So people followed up the immune response. And what many countries went into was giving the 4th dose, but to targeted population. I think we have to start recognizing this with COVID. This is an infection that came, it affected the world, it's a pandemic, it will become endemic, and it would be something that we will live with. So this will be there for some time, and we have to target and protect our vulnerable populations. So the vulnerable population, if you look at from an immune response, anyone over the age of 75, people with immune deficiency, people who are taking steroids or other immunosuppressive medication, people with liver disease, renal disease, hematological condition. That is the population that you wouldn't want them to be cancers. You wouldn't want them to be having a suboptimal immune response. So you wouldn't rush to give the 4th dose to people who are absolutely healthy, because the 3rd dose is preventing them going to hospital, it's preventing them getting ICU care. You would take the 4th dose for the people who are at higher risk, or the older population who we know. And that is why in my slide I showed that the older population would not make an immune response. It can be SARS-CoV-2 or any bacterial virus. The immune response is poor. So that is the population you target, you give the vaccine. And as more data comes in, we know the COV-BOOST study, which was released last week, the Israeli study, etc., showing that the immune response is occurring, but that has to be targeted with the clinical aspects to see whether the general population should be given this vaccine in addition to the target group. So the target group will get it. Now the question occurs about the world. We know that certain countries have winter coming up in a few months' time. And we know that respiratory infections increase during winter, whether it be just a normal viral infection, or it can be flu or SARS-CoV-2. So therefore, we have to target that aspect also with making the consideration about the fourth vaccine for people, because we know that you don't want to go into winter with that subgroup of people who are not exactly immune deficient, who are not having 100%, 90% or 95% immunity, but in between, where do we target? So the age range will decrease after some time, and therefore those decisions will be made in the next few weeks, at least by the end of June or mid-July, so that people can get ready for the winter that is coming up. And with regards to Sri Lanka, I would say a targeted approach would be far better rather than going with the whole, because target your older population plus the immune deficient and the cancer patient initially.
Sir, you had mentioned there's a slide about immune response after first, second, third. Is it a response came from the same type of vaccination or mix of it was happening in Sri Lanka? That's why I'm asking.
Very good question. So this was a question that I think was asked over and over again many months ago, because there was a vaccine shortage and people were having to mix and match vaccines. And I can remember giving many talks about mixing and matching many months ago. Then we found that actually mixing and matching, that is a viral vector vaccines like AstraZeneca or J&J, and then following up with mRNA vaccines like Pfizer, Moderna, was really beneficial because it was increasing the immune response. There was a better immune response if you gave the viral vector vaccine and then followed up with the mRNA vaccine. Now that happened in Sri Lanka, but in several countries where viral vector vaccines were not given less than 40 years of age. So you found the response was better. And then they found, when they did the COV-BOOST study, that the mRNA vaccines were the ones that you should use with regards to the third dose and the fourth dose. Those are better vaccine. And that is why, say, in a country like the UK, the third dose was, even those who received AstraZeneca, they received Pfizer. In many countries, including Sri Lanka, where Pfizer was given, Moderna, again, was a vaccine that they use. And certain studies show that Moderna may be a little bit better than Pfizer, but equivalently, I would say both are similar. So most of the studies with regards to third and fourth have been using the mRNA vaccines, and there was a boost of antibody response and cellular response after the third dose. And the fourth dose, again, there was a boost, which you would expect. You're giving antigen, there would be. But, we cannot go to the situation that every 4 or 5 months we are giving another vaccine, etc. It will stabilize, it will come on to, and it will most likely, but many people are believing at the moment, is it may come to like the flu vaccine pathway, that we would need it annually, but that again could change as more data comes in. So we just cannot keep on giving boosters every 3-4 months. That will bankrupt the world, as many places find that they cannot do that. That is why we have to focus on other measures, antivirals, appropriate social measures, etc., to keep this pandemic under, and bring it into endemicity and then reduce it.
Yeah. Can I ask one more question, Chair? This I directed to Melanie, especially for us GPs again, because we find lots of people who have avoided the third vaccine here in this country because of rumors spread amongst the community. And it's terrible because, however much we tell, they say, no, this one told me, that one told me, these are the side effects of even the vaccination site. They say it's going on for months, which I think is just imaginable. What is your experience there? Then one more question. The psychological impact of all this amongst your general practice population. 2 week questions.
Yeah, it's a very, I think it's a very important, pertinent question you're asking. Because I do have patients also complaining of these similar issues. Vaccine site pain. But the thing is, usually the symptoms subside. So I think, you just have to explain and say that it's going to go, I think the question I ask is, is it, if you sort of grade it, what is the pain, has it reduced? So then you can say, yes, it's reducing, so it's going to go away. Because there are vaccine site pain. There's studies that you can have vaccine site pain. So that's something you can tell the patient. And you mentioned about vaccine hesitancy. Is there a particular, would they come with a particular reason for it, or is it just a general?
Yeah, I'll come back to that. Yes, vaccine hesitancy mainly was with young men. The word spread around that they're going to become impotent, so they just dropped out from the thing. And it's become huge, to convince them it's all nonsense. I don't know. What is yours?
Exactly.
Yeah.
I think if I just can come in there also, it's very important because there are two groups. There is a vaccine hesitant group and the anti-vaxxers or the vaccine people who will never get a vaccine. So I think the important thing from primary care, because this is the population with me in primary care, it is where the specialist and primary care would work in tandem together with the researchers to pass on the message, because many a time people were asking infertility, impotence, problems with pregnancy, cancer. If you can remember, initially patients with cancer in the UK, in Sri Lanka, were told don't get the vaccine. They should not go. That was absolutely sort of opposite of what they should have been told. And at one time, people were told, people with who are smoking don't get the vaccine. People who are taking alcohol don't get the vaccine. 6 months, if you are taking alcohol, you can't get the vaccine for 6 months. Those are all the sort of myths that had to be brought in. And I think this impotence and the infertility was absolutely looked in. There's absolutely noted, and that is where I think the primary care working with the specialists is important and the researchers in the area, because that gives in people would like to know. They have access to Google, they have access to different social media platforms. It's important to pass on the message. Previously, scientists, researchers were just in the room, not talking to anybody, not coming out and not mentioning any facts. And that's the change that COVID brought about. It forced researchers and consultants who were generally closeted and not only talking in very advanced terms that no one else could understand, to come, talk to the people, explain in easy ways so that people can understand and take the message to everyone and their family.
Can I ask a question? As to the second booster dose, as per your response, you said it should be targeted for people over 75 or high-risk patients. That is the scientific evidence available at the moment. But as far as Sri Lanka is concerned, with all this economic crisis going on, we have vaccines. I think it is going to expire in July end. So by the time your scientific evidence comes through, I think we might not be in a position to get vaccines if the science changes. So would you suggest asking people over 60, comorbid conditions, and high-risk people, without waiting for scientific evidence to come, to get the vaccine? Because I think government is having enough vaccines, but it is expiring in July. So do you think that is a good suggestion?
I think I think that's a policy decision which each country has to take. I mean, different countries have to take policy decisions. It's a pity to be able to sort of throw vaccines because it's such a difficult commodity to arrive at. But at the same time, we have to ensure that the vaccines are targeted to the correct population. Now, when it comes to 60 years with comorbid, if you look at it scientifically, if you look at it sort of from an immunological perspective, that is a population, there won't be big harm done. I mean, that's important. We don't do harm to people. That's important as well. Because in the UK, it was coming, the discussion was over 50, anyone over the age of 50 to be getting the 4th dose of vaccine together with anyone with with high risk comorbid features that can increase the risk of COVID. That 50 years did not come. They thought it might come in there, but the number of cases sort of stabilized. So I think that is a policy decision that the people who know COVID very well in the country should be able to discuss that around the table and come to a consensus decision and put it out to people. Because I mean, if the thing that the UK is going 75 high risk population, we have to remember we are in summer and it's a different population which may suddenly change when it comes to August. So I think that is a policy decision which people would have to consider. And I wouldn't say that 60 years with comorbid features, if I was having a lot of comorbid features and 60 years, I would advise that person to go with the 4th dose of COVID vaccine because it has been found to be safe. We know that's safe. 3 big studies have been done. It's found to be safe, right? And the important thing is it's not going to cause them harm. That's important. And that's a policy decision that the government, the scientists should make, and the clinicians.
I saw it being announced that in the papers that anyone over the age of 50 or 60 can come for the vaccine.
Because the story going around is because government is having enough vaccines, that's why they are pressurizing people to get it.
By choice.
Yeah, so that's why I asked. I mean, because you said that it is
I think that pressurizing, I think it depends on the amount of vaccines that a country has, targeting at the correct time. Now in the UK, I think the correct thing would be to target it around sort of August, because we are going into winter, fall and the winter, autumn and winter. And I think so you don't want to give it too early. So therefore you give it at the appropriate state. Now, I think the important thing is vaccination. The message should be the benefits of vaccination. And because if you tell people that you're forced to get a vaccine, etc., that is really going to be counterproductive. The benefits of and the issues with long COVID, the issues that we're having, the cardiovascular, the neurological, the other effects of the general effects, the rheumatological, renal effect. And I think when people begin to recognize that will be more people, and that's what a vaccine hesitant person has, the question, that's important that we address the question. While the anti-vaxxers or the vaccine skeptics, I mean, you can tell them till you go blue in your face that, vaccines have the positive benefit in COVID, they will not believe it. So it's the important thing to explain these questions one by one and to answer them, absolutely. And the benefits of the vaccination.
Thank you.
Yeah, we will bring the session to a close now. Dr. Melanie Veerasoorya and Professor Suranjit, thank you very much for your time and for your valuable expertise. We have benefited much. We are at a stage where we are now supposed to give you a token from the college and a certificate of appreciation. But as you know, the distance is a little too much for us to do that. So when you drop in back home, please let us know. We will do the needful. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you very
Thank
much.
you. Thank you.
Thank you.
Okay, this brings us to the next talk, a somewhat intriguing talk. And first, let me introduce the speaker. Dr. Ruiz Hanifa is the head of Department of Family Medicine, Faculty of Medicine, University of Colombo, consultant family physician. Principal Family Physician, Healthy Life Clinic. He was a member of the University Grants Commission of Sri Lanka, 2015 to 2020. He is the past president of the Sri Lanka Medical Association. He is an examiner at undergraduate level in the discipline of medicine, allied health sciences, and nursing, and a postgraduate examiner in family medicine, community medicine, and medical administration. At the international level, he has been functioning as an examiner at the MRCGP International South Asia Board since 2008. He has 20 publications on related topics in local and international peer-reviewed journals. He has authored chapters to 2 medical books, and most importantly, his contribution as chapter author to the book History of Medicine in Sri Lanka, 1948 to 2017, on general practice family medicine, remains an authoritative work for us. And according to Ruiz, his teaching philosophy is not to clone himself, thank God, but to allow his partners in education to achieve their higher standards of professional conduct in their own right. Ladies and gentlemen, a difficult patient or a difficult doctor by another doctor, Ruiz Hanifa.
Thank you, Dr. Eugene, for those very kind words of introduction. Chairpersons, members of the College of General Practitioners, thank you for inviting me, for asking me to speak to you on this topic, which is for GPs, I think, very important. As undergraduates, postgraduates, and even postgraduate, we are told about difficult patients. But there is another side to the coin, which is not looked at. So my primary topic was actually difficult patient, but then to this very erudite audience, that is not challenging enough, I thought. So don't worry, there is a lot of elements of difficult patients in this half an hour presentation. But let's go beyond, because our theme is also emerging challenges in general practice. So with that, difficult patients, as they are classified, I'll tell you the definition in a little while, compose about 15% of the ambulatory visits in the United States. Similarly, in the United Kingdom and other developed countries, but in Sri Lanka, I have not found any data, so I don't know the exact figure, maybe more, maybe less. Of course, this 15%, there is pronounced discordance between the perspective of physicians and patients. That is acknowledged in this article published in Family Medicine in 2015, which is the source which talks of the prevalence of 15% of difficult patients. So it's important to identify some concepts before we classify or go on to understand who a difficult patient is. So as all scientists do, before we go into a topic, we review the literature. But be careful when you do that. You'll have to be very careful, because the literature itself looks at the doctor-patient relationship from the perspective of the doctor. So it is a biased review of literature from our part, which is published in these journals. For example, we have no patients writing to a medical journal saying, I am a difficult patient, or for that matter, this is what a difficult doctor should be. So therefore, it is important to understand that when you do a literature review on, for in that matter, any controversial subject, better go to the source document and really study it. So that brings me to 2 questions, which I hope will bother you as much as it bothered me in preparing for this lecture. So in actual reality, when we see our patients, is it the patients who have the difficulties and we the doctors who have the problem? Or is it the patients who have the problem and we have the difficulty? For example, we have difficult patients, maybe due to knowledge issues, due to experience issues, and so on. But that is actually not the patient's problem. That is our problem. The difficulty is with us, but the problem is with the patient. So we need to get this very clear. So why does this happen? Why are these concepts of difficult patients and all happening to us? That is because GPs are trained, and we continue to be trained in the biomedical model. The answer of a biomedical model is a one-dimensional approach to multidimensional problems we see as GPs. The previous speaker, not the GP, Professor Suranjit, he's a good friend of mine anyway, who spoke about COVID. One problem. But when the patient becomes long COVID, he can explain the pathophysiology. Absolutely, he can't yet, but we will be able to. But we have so many other problems, multidimensional issues. Therefore, a biomedical model essentially deals with an entity which is definable, which has a pathophysiology, which has immunopathophysiology or whatever. The more dangerous thing is we, as a medical community, have also trained our patients, like Pavlov did his dog, to expect the same one-dimensional solution for the multidimensional problems they have. So when they come to us, they demand that they be treated in 1 minute or I don't know, whatever it is. They need a treatment for their headache or backache or whatever, one-dimensional issue. But as doctors, we need, especially as GPs, we need to realize that there are multi-dimensions to this issue. Going on, traditional medical educations deals with scientific inquiry. They say medicine is a matter of science, and it becomes important to people only when that science goes to people, and it solves 1 or 2 problems. So we as GPs are, due to our training, the modules we go through, are forced to decide whether a patient is diseased or not. In fact, if a patient, you can diagnose a disease, you are very happy because you can follow some protocol, you can, you're very happy if that happens. But what you have to realize is there are 2 levels you're dealing as a general practitioner. First is a micro level, which you must deal with, which is a biomedical model for pain, high blood sugar, high blood pressure, high serum uric acid, high, whatever parameter, high fever, whatever parameter you're dealing with. That is a biomedical thing. But if a patient has a fever, how will he behave? What are his myths about the vaccine? There was a huge discussion. That is the macro level. One has to deal with the complex relationships of individuals, families, and the community. A failure to do so, to deal with this micro and macro level, is going to make a difficult patient. I am not saying that we make difficult patients, but if you don't recognize this as an expert or a generalist in your field, you are going to make a mistake. So these are the definitions of difficult patients from doctor's perspective. I will just refer you to the second bullet point. It is actually an article. It's called Hateful Patients. And it is published in no less a journal than a New England Journal of Medicine. It was a long time ago. But can you see the despise the doctor has in their patients? The article is called Hateful Patient. Okay, so the accepted definition of a difficult patient is a patient who consistently triggers negative feelings in the physician who cannot satisfy the endless demands and complaint. So that brings me to the last point, which summarizes the first point. They are called heart-sink patients. The moment the patient, you see him or you see his file in front of you, you say, oh God, not again. Right? We all have our patients like that, right? And to go on, I won't talk about the hateful patient where he goes to defend. I think it's quite offensive, but now things like this don't happen. Then there's another definition, a patient with whom the physician has trouble forming an effective working relationship. All this basically is a doctor-patient relationship issue. So John Murtagh took a little different view, like the issue I also had, as to who has the problem and who has the difficulty. So he doesn't have any difficult patients, but he tries to figure out the relationship. We all have our panel of difficult patients. That's what makes our practice so interesting. Right, so I did the next thing and tried to look for difficult doctors by doctors. Rare to find the articles, but managed to find one which is of some relevance and which was from a very reputed journal. So they talk about difficult doctors, but they go on into, if you look at the shaded area, they talk about practice setting, the hours of work, and so on. This article concluded, so they didn't call them difficult, though the title said. When you look at the conclusion, it says, are the highly frustrated physicians we deal with difficult doctors? So they are not actually classifying them as difficult. They are saying, okay, these people may be frustrated due to various reasons, such as facing varied personal and clinical challenges. Therefore, they become difficult. But actually, that is not the patient's problem. Among them, there may be physicians with inadequately equipped to address complex issues, that's the knowledge gaps, and so on. Therefore, we need to better understand the role of the physician plays in frustrating the doctor-patient relationship. I think that is the important thing. Either way, both parties can become difficult if the relationship is not worked on or identified and appreciated. Therefore, we need to understand this, and these are the two questions again, which we'll try to answer in the next few minutes. Who has the difficulty and who has the problem? So, you know the definition now, so what are the possible causes of this issue? So, we have been taught, or we know that, you have to have a 3D, 4D, or, some holistic view basically, and it should be patient-centered, in the sense that you have to address physical, mental, and social signs and symptoms in the individual, family, and the community, and you have to deliver promotive, preventive, curative, palliative care in an ethical or professional manner. So in delivering this care, difficulty can occur at any point. For example, the signs and symptoms. If you can't interpret the signs and symptoms the patient is telling you due to some reason, lack of knowledge and lack of updates, or the patient is not giving you a proper history, you are going to run into problems. Then in identifying individual, families, and the community, if you are not differentiating the micro and macro level which impact that relationship, again, you are going to run into difficulties. Also care provision. You might want to get an MRI scan done, but availability, accessibility, affordability, and acceptability are going to become an issue, especially from a primary care perspective. Please do not forget, and this I have found no articles on this, about issues of ethics and professionalism leading to difficult patients and difficult doctors. Probably if we are not ethical and not professional, we won't see ourselves as difficult doctors. But the patients might. But we are not capturing that in our research. This is another way of looking at it, where there are patient factors, doctor factors, and system factors. Same thing I have said, but a little bit of details where we're getting into the theory part of the difficult patient. The patient factors could be psychiatric disorders. Yes, they are difficult patients. Personality disorder and subclinical behavior traits. I want to focus on subclinical behavior traits because that is very important. We just finished long COVID. So they are all subclinical behavior traits. You might not be able to identify any particular disease pattern or anything because we deal with undifferentiated patients, and most of our clinicals are subclinical behavior traits. Doctor factors, I will not go through, it's already there. System factors, yes, wherever the system, even the world's best primary care system, you have issues. But I would like to finish this slide with a very nice quote from a study published in the Family Practitioner in 2001. Interestingly, the more experienced the doctor is, the less he perceives the patient as difficult, as he learns to accept greater diversity of behavior in his patients. So this is indeed a fact. I think long time ago, I heard it from Dr. Aloysius. It's good to remind him here today. He said that when he started out, I think he was also quoting somebody, he had 20 drugs for one disease, But when he ended up practicing, he had one drug for 20 diseases. So that's how you expect diversity and you start to appreciate things. So what actually happens when you really analyze it is that individuals who try desperately to get his or her needs met, the only way they see possible at a particular point of time. As they perceive the experience of little success with the doctor, they become frustrated. So please remember, in these hard times ahead, you are going to see a host of social issues which are going to turn up as clinical problems for you. So please don't medicalize them, identify them as social, and don't make them difficult patients. So characteristics, you can find this in any decent medical textbook of a difficult patient are multiple symptoms, undifferentiated illness, which we should be masters of, negative investigations. I think all of you have seen this. They are convinced that there is something wrong. Then dissatisfied with treatment or procedures. I went to do a endoscopy or whatever. Nobody told me anything. I don't know what happened. I don't think it. So things like that. So they are not satisfied. Attending multiple caregivers, yes, that's also an issue because of there is no shared care, but there is domination of care, I would say. Taking multiple drugs and frequent attendance for trivial problems. These are the issues. So these are basically from the doctor's side. The one on your left is from the patient side. Patients, by their character, can be demanding on a manipulative, non-compliant, all-knowing. Garrulous means they go on talking about trivial things. The other extreme is uncommunicative. They come and cause problems with your staff and have no consideration for your time. So those are the patient issues which you have to know. So just to complete the talk, because the initial talk was intended as a difficult patient, so I had chosen just 4. The hypochondriacal patient, the chronic complainant, the depressed patient, and the angry patient, which sort of covers the spectra of a difficult patient from a doctor's perspective. So hypochondriacal patients are the worried well. There's actually nothing really wrong with them other than some minor neurosis perhaps. They are preoccupied with every symptom. They think that health is symptom free, that you can't have anything, you have to be perfect all the time. So this is actually the basis of their numerous somatic complaints and resistance to reassurance by you. This is where the doctor-patient relationship comes. If you look at the definition of a consultation, it says where you consult a doctor you trust in. If you establish that, these things should not occur as much as they would. Therefore, the hypochondriacal patient focuses on their physical symptoms. In reality, what happens is they're actually suffering from anxiety and depression while being unsuccessful to find somebody to quote-unquote cure them. So the best way to handle them is to benefit from regular visits, but you need to time them. We'll come to the management at the end of all this. You must acknowledge that they have an issue, and the objective should be to make them realize and appreciate that the number and intensity of their symptoms is directly correlated to their stress or anxiety levels. The chronic complainer, now the hypochondriacal patient, the established thing is that they are the worried well. So I try to come up with the chronic complainer. He is the diseased unwell. It means he has an issue and he is unwell also. Multiple complaints, they demand to see you all the time. Rarely gets better with anything. Backache is a good example. Actually, you can show that there is a backache or whatever, but even after this, spinal surgery or decompression, still the pain lasts. Maybe there is a pathophysiology we don't know yet. Never appreciates the effort on their behalf, and the patient seems to need, they need their disease to function. There is maybe a rarity if you say there is no disease, they might just stop functioning and stop being existent also. Management is also, will come to the end. Depressed patient is a difficult patient with actual clinical entity. We see this subclinical behavior, and depression is one of the most commonest subclinical situations presenting to a primary care physician. Even mild to moderate depression affects people's lives very, very negatively, and the quality of life is sometimes very bad. The angry patient, I think all of you have dealt with them. They are the anger of the patient and his family sometimes. It may be towards you or maybe towards the healthcare system itself, which provokes a wide length and breadth of internal, maybe his issues not being, his experience with the health system might not be good. The anger may be concealed or overt, right? It may be communicated as fear or insecurity. Even silent people could be very angry with you or your practice. So that's the overview. And a few practice tips. I think there are just 2 slides before we wind up. We have to identify our professional responsibility. We need to rise above the interpersonal conflicts and facilitate a productive communication by establishing a caring and responsible relationship with the patient. Basically, the professionalism of every consultation you undertake. The consensus in the international literature is to give up trying to cure them, accept their symptoms as expressions of their neurosis, and structure a program for them, which is limit your time with them, give them about 15 to 20 minutes. This is an international figure. You can vary according to not less than 15 minutes, I suppose, regardless of the complexity of their problem or the number of complaints. Part of this time must be spent in integrating medical and psychosocial concerns, because health is mental, physical, and social, so not only the physical part. So you need to have some skills in counseling and therapeutically addressing them, not to suggest anything, but I think most of us have this skill as GPs, as counselors. If all problems cannot be addressed in a single issue, you face the issues out. So what do we get out of this? Difficult patients do exist. Please identify them, and also if they are difficult, do not miss the diagnosis of an organic disease. At the same time, do not diagnose an organic disease in a difficult patient who doesn't have one. Please reflect on, is the patient's problem difficult to you? If so, read up, attend some courses, and update your knowledge. Is the patient with the problem your difficulty? That is not his clinical problem, but how you deal with him, the doctor-patient relationship. Please also don't feel afraid to ask the question, could I be the cause of the patient's problem being difficult? So my last take-home message in today's audience for you is, what do we do about difficult us? So these are the challenges professional bodies, the College of General Practitioners or whatever specialty you're in, or national medical associations should deal with. And I think these should be students, medical students should, or even postgraduate students definitely, should be able to, or given the skills to, as it were, looking inward or turn the light inward and reflect and see. This is where your practice audits, your reflections, the errors you make, so on, become very, very important. If I may, with the permission of the chair, where your portfolio, if you go to the MCGP training, is extremely important to develop that skill so that you start looking inward, and hopefully we will do more research into a patient's definition of a difficult doctor, because this is a two-way street, and we too have to take the responsibility of causing difficulty in our patients, intended or unintended. Thank you very much for your patient hearing.
Thank you, Ruves, for that very provocative presentation. Are there any questions?
Don't ask me the last one because I don't have an answer for it.
So I do have a question for you. Based on the light of recent political developments, what are our grounds on refusing care for a patient like this? Do we have a right to refuse patient care? Just to clarify.
So that's a difficult question. So,
I'm sorry to put you on the spot.
Yes, sir.
I like to answer that.
Sorry, sir, we have?
We shouldn't reduce anything.
No, refuse to treat, I meant.
No,
sir.
we can't.
Okay.
We can't at any point.
At
I
least
treated a patient who was brought by the police from far away place, who was caught for drug smuggling, and they didn't have a doctor, he had injuries all over. So I treated. I mean, our duty is to treat patients, not to refuse anybody at any given time if we are working. That's my motto.
Yeah, if I was just to add to that, yeah, so the basics of medicine is healing. So if you can facilitate that process in any way, you should. But if you have conflicts of interest, if you have doubts about your ability to perform that task, you should facilitate the treatment in the way you see most fit. It works both ways, the doctors also can abuse it, patients also can abuse it. So this is a good debate. Maybe the college should have a debate on this sometime, because but the bottom line, like Dr. Preeti said, is we are healers and we need to heal.
Can I add one more? Sunet, since you asked this question, we do have a lot of difficult patients we just can't manage. Whatever we say, there's so then you can say, look, I don't think I can handle your problem, so can I ask somebody else to talk to you? That kind of thing.
That's where, sir, now if you're getting a little more technical, that's where I think that those who have been through the MCGP or any postgraduate training program, we have different models of consultation. So you switch between one or two and you try, and if you fail, yes, you need to get the help you need. So do update yourselves on the various consultation techniques we have in family practice.
We have one way of dealing with difficult patients, that's to give them a present. So, Ruiz, come and collect yours.
Right, and with that, we will move on to the last item of the day, which is the picture quiz in dermatology at a glance. For this, I would like to invite our resource person, Dr. J.T. N. Arya Singha. And it is a great pleasure for me to introduce Dr. Arya Singha to you. And while going through his illustrious career, one of the most interesting things I noticed is he's a product of Royal College, an old royalist. So I'm sure it's not every day that you're outnumbered on an academic stage by Thomians, but you are today. So Dr. Arya Singha is a consultant dermatologist and director of the Specialist Skin Clinic in Colombo. He is a dermatology fellow at Sinclair Dermatology, Melbourne. He is, as I said, an old royalist and also from the Faculty of Medicine in Colombo. He has training and fellowships at the Royal London Hospital as well as the Whipps Cross Hospital. He has been a consultant dermatologist in the Ministry of Health from 2017 to 2019. He is the past vice president of the Sri Lanka College of Dermatologists. He is the joint secretary and founder member of the SARC Aesthetic Association in Dermatology. He is a member of, and this I had to cut for time because he's a member of a number of illustrious colleges. He is a member of the American Academy of Dermatology, the American Academy of Dermatology Research, the Australian Society of Dermatology Research, and the International Society of Dermatology. With over a dozen publications and nearly double that in scientific presentations, Dr. Arya Singha is truly a giant in dermatology, and it is an honor to have you here. Over to you, sir.
Thank you for kind words. The honor is mine to be here before this distinguished group of colleagues. I would like to thank the college for giving me this opportunity to present. And also, it's a very exciting moment, and I'm proud to be here before my brother, who is a fellow of the Australian College of General Practitioners and a very skilled dermatosurgeon, skin cancer surgeon. Yes, so it's a special moment for me. So, dermatology is a vast field and something extremely important to the general practitioner. I reckon it's about 30% of your patients have skin issues. And let's start with the ABC or the alphabet of dermatology. In dermatology examination, it's very important to know how to describe the lesions. Without that, you cannot go any further. So, I'm sorry I was late in sending in the presentation, so I'll have to go through the questions and get you to raise your hands depending on what you agree. So out of this, who would go with number 1? The order for A, for B, for C, D, E, and F. Who would go with number 2? Number 3? Number 4? Number 5? Okay. So I'll just tell you what it is. Now, I'm sure all of you all know something about it. We call maculopapular rash. So when you say macule, it's a flat patch, a flat lesion that has a color or a textural change, which is not raised. If it's small, if it's less than 0.5 centimeters, we call it a macule. If it's larger, it's a patch. When it's fluid-filled, raised lesion, we call it a vesicle. When it's large, we call it a bulle. When it's pus-filled, it's a pustule. Solid lesions that are small are papules that are raised, dome-shaped. They are large, more than 1 centimeter, they are nodules. And flat-top lesions are plaques. And when there's a wheal, edema, swelling, and a flare, redness, we call them the wheals. When there's a wheal and a flare, the wheal is actually seen in urticarial lesions, which are quite figure 8, which you see in F rather. So in addition, there are a lot of others that you know. You know the petechiae, purpura, ecchymotic patches, I'm sure. And then there are secondary lesions, which are changes that occur in primary lesions. For example, so when there is a discontinuation, this ulcer you would recognize, but this is on a background of petechiae. So in this case, it will help us diagnose a vasculitic ulcer. There can be crust on top of vesicles, and these are honey-colored crusts, suggestive of impetigo, diagnostic of impetigo. There can be scales, like a colloidal scales in an erythematous patch or a plaque in pityriasis rosea. There can be superficial erosions. These are fissures. When there's break in an eczema, these are fissures. Then there can be scratch marks, which we call excoriation in eczema. When they thicken out, we call them lichenification. And there are many more. These are all features, secondary lesions. And some can take patterns. These patterns allow us to come up with a differential diagnosis and to zoom in on the diagnosis. So this is a linear lichen planus, epidermal nevus. This is a pearl of strings in linear IgA disease. When they are grouped pustules or vesicles, we think of herpes simplex or dermatitis herpetiformis. Raindrop or guttate type of lesions, idiopathic guttate hypermelanosis. Serpiginous lesions, this is cutaneous lava migrans. Then there can be discoid lesions with the eczema testing. This is a discoid eczema. And let's go to the second question. This is an 8-year-old boy presents with these ill-defined patches on his cheeks. He has a history of moderate atopic eczema, which is controlled with 1% hydrocortisone cream and emollients. What is the most likely diagnosis? Anybody for vitiligo? Pityriasis alba? Steroid-induced hypopigmentation? Lepomatous leprosy? Ash leaf macule? Okay. Now, vitiligo it's not. Why? It's depigmented. This is hypopigmented. Depigmented is like completely lack of color. Pityriasis alba is the diagnosis. It may start as a slight erythematous, but by the time we see it, it's a hypopigmented patch on a background of dry skin. There can be multiple patches. There's a slight scale. Steroid-induced hypopigmentation is possible, but there may be atrophy. And also with hydrocortisone for a short duration, very unlikely to cause atrophy, but it's a possibility. But with this clinical pattern, it's more like pityriasis alba. Now, the thing is, there are various other conditions that we come across. Commonly, the photodermatitis that we see in this over the zygoma and up to the malar area, hypopigmented patches. Then there's tinea versicolor that starts as tiny macules around the hair follicles and they spread by confluence become larger patches. So they have this distinct appearance. And finally, but I would say the most important thing in our region not to miss is tuberculoid leprosy. You can present with a hypopigmented patch, which may have a raised erythematous border, or it may merge with the surrounding skin. It's important to test the sensation, but sometimes on the face, because there is cross supply of by nerve endings, you may not lose the sensation. But it's also important to look for other thickened nerves around the area, as well as other large nerve trunks that are thickened in tuberculoid leprosy. And we normally do a biopsy, so if in doubt, you should always refer. Now, this 8-month-old child presents with this symmetrical eruption on cheeks, elbows, and anterior aspect of shins. It responded well to hydrocortisone, but flares when stopped. What is the likely cause? Anybody for 1, 2, 3, 4, 5. So everyone agrees this is a common condition that you all see. And so dry skin you see, and it's very itchy. History of atopy or family history of atopy. And then it has a remitting and relapsing course. And the pattern changes. Early in life, in infancy, it's the cheeks, the extensor aspects, then it comes to the flexures as they get older, and later ends up on the face, hands, round neck, and maybe the entire body. So that is atopic eczema. It can be also associated with pityriasis alba, ichthyosis vulgaris, hyperlinear palms, and keratosis pilaris, thickening of the hair follicles that you see with sometimes erythema. In our skin, we may not see that. Now, the same child comes with worsening of the rash after a few weeks. On examination, had grouped erosions. What should you do? Should you step up your treatment and start on a moderate potent steroid because it's not unresponsive to hydrocortisone? Or urgently refer to a dermatologist? Now, what shouldn't you do? Start on oral acyclovir, use antihistamines, use emollients, and mild antiseptic washers. So, what shouldn't you do? Is it number 1? Correct, it's number 1. Why? This is eczema herpeticum. It's a herpes simplex. In early lesions, you would see vesiculation or umbilicated lesions in a grouped appearance, and later there'll be just the erosions. It can spread like wildfire, and it can be also fatal, so it's very important to treat it urgently. A 82-year-old lady who you have been treating for eczema on her both legs, which is shown in A, with emollients and betamethasone neomycin combination for 2 years, presents with widespread eczematous rash covering most of her limbs and back. What explains this new rash? Is it 1, disseminated eczema with allergic contact dermatitis to neomycin? Disseminated eczema with allergic contact dermatitis to betamethasone? Secondary steatotic eczema? Disseminated staphylococcal infection? Development of nummular eczema? Anybody for 1? Anybody for 2? 3, 4, 5? No. Okay. So the thing is, when you use a combination of betamethasone and neomycin, dermatologists almost never use this combination with neomycin now, because neomycin causes contact allergy, and this allergy can have a secondary dissemination. And this can happen in various things, even in a fungal infection of the foot. In stasis dermatitis, you get secondary eczematous spread, which is called an ID reaction. And the explanation, the immune process, because of I always tell my patients, it's like having a war in the north, and you have so many soldiers, and all of a sudden they go to the south and start a war. So they can start a war all over because they're hypersensitized immune system that is there. So, okay. Number 6, what is the least correct of the following in management of eczema? Barrier enhancement with use of emollients and soap-free washers is important in treatment as well as prevention. Any proof of that? If causative allergen or irritant is identified, it should be avoided. Betamethasone valerate cream for 6 weeks will be the treatment of choice for eczema of the face. Striae, red face syndrome, perioral dermatitis, tinea incognito, growth retardation are possible side effects of topical steroids. Allergy to topical steroids is a recognized phenomenon. So anybody for one? I'm asking for the least correct. Anybody for 1, 2, 3? Very good. 4, 5. So it's great to see that, because in management of eczema, important thing is, this is something drawn by my daughter a long time ago. So it's important, the skin acts as a barrier. The oily layer that sits on top in the stratum corneum repels things. If you use a lot of soaps, especially soaps that are foaming soaps, that will sapponify and remove the oils, you'll have a naked skin and everything comes in the allergens, irritants, and that causes an immune reaction. So we use steroids to reduce the immune reaction, but no point using it if you don't fortify the wall. So it's very important to use emollients and soap-free washes. And another important thing is, we use many steroids, but we don't know where they fall in the category of potency and the side effects. So the most highest potent ones are the betamethasone dipropionate, the potent ones like betamethasone valerate, and the least ones are hydrocortisone. It's safe to use hydrocortisone, but not betamethasone valerate, dipropionate, and clobetasol on certain areas. So these are like common brands you would be knowing, but so it's important to know what they are and where they fall. Why? Because the eyelids are 300 times more, there's 300 times more absorption through the eyelids than the palms and the soles of the feet. So it's very important to choose them right, otherwise you end up with side effects. And it can cause irreversible striae, perioral dermatitis like a worsening acne, red face syndrome like rosacea, thinning of the skin, skin atrophy, and tinea incognito, and as well as systemically, it can cause suppression of the pituitary hypothalamic axis. Now, steroids can rarely come as positive in a patch test, in about 5%. So it's not unknown to have steroid allergy. So if you're using the same steroid, it may not work. You may have to change the class. So it's important to understand steroids themselves can cause allergies when you're using not the vehicle, not the other preservatives, but the steroid itself can cause it. This 30-year-old lady who has been having acne for 5 years and on treatment presents to you saying it got exacerbated after stopping chemical peels. What is the most appropriate step in management? This is something commonly I see, and this is a message I try to drive home all the time, what should be done and what shouldn't be. Should you start on topical betamethasone or mometasone furoate cream with oral antibiotics? Recommend chemical peels with topical hydrocortisone under antibiotic cover. Start oral prednisolone 25 milligrams daily, taper down over 2 months. Start topical benzoyl peroxide in the morning and with clindamycin benzoyl peroxide combination in the night with oral antibiotics. Refer to a dermatologist to consider oral isotretinoin. Yes, this is a difficult situation because there are a lot of aestheticians and non-specialists generally doing a lot of chemical peels. Using steroids, it gives a beautiful face for a while, but it causes lots of problems, steroid red face syndrome, aggravation of acne, rosacea-like conditions. And in this situation, if it continues, it's going to cause atrophy, telangiectasia, and scarring of the face. It's very important to treat early, but it's extremely difficult. So what we normally do is we add isotretinoin with oral steroids and very tapering off of the steroids. But potent steroids should never ever be applied on the face. That's like something extremely important to understand. And steroids have no place in treatment of acne unless we sometimes use it for very resistant acne, cysts, and nodules, there's an intralesional steroids given at a low concentration, but not otherwise, not as topical steroids. Acne treatment, well, it's quite an extensive topic, but few important points. If you're using an antibiotic, topical or oral, always use benzoyl peroxide because antiseptic prevents antibiotic resistance. Do not combine dissimilar antibiotics as topical and oral because it's going to cause antibiotic resistance. Antibiotic resistance will have very significant implications because you may try to use a similar antibiotic for a serious life-threatening condition and it will not work. And also through plasmid transfer, they can go into other bacteria as well, not just Propionibacter acne that will develop resistance. Refer for early treatment addressing to address the cause or sort of oral isotretinoin because we start oral isotretinoin very early now to prevent scarring, and in fact at very low doses it's quite safe, but it has to be done by a dermatologist. All around the world that's how it is treated. An obese lady with previous diagnosis of psoriasis has these lesions for a week with fever for 1 day. What is correct regarding her management? Give steroids plus antibiotic cream, fusidic acid, betamethasone cream with oral antibiotics. Urgent referral to a dermatologist as this could be pustular psoriasis. Refer to a surgeon as this is likely to be cellulitis. Start an oral antibiotic and topical coal tar cream as steroids may mask infection. In a long-term management, addressing metabolic syndrome will not have bearing on her psoriasis or vice versa. 1, 2, 3, 4, 5. So I'm happy what I saw. The important thing is to understand this psoriasis. When you see pustulation erythema, it's not really an infection. It's most often, it's a rare condition, but when you see it, you have to think of pustular psoriasis, unstable psoriasis. It can go into pustular psoriasis. So it has to be managed by somebody who is competent in managing pustular psoriasis. Another important thing about this is long-term management of psoriasis, a GP has a very important role to play. The psoriasis increases the cardiovascular morbidity and mortality associated with metabolic syndrome. And also treating the metabolic syndrome and weight loss, decreasing obesity will have positive effect on psoriasis. So it's very important. A 15-year-old boy presents with a 2-week history of a rash. He describes a single lesion that appeared on his back that gradually enlarged over a few days, and then within a couple of days, multiple lesions appeared over the trunk and proximal limbs. What is the least appropriate action? Now, this is a oval patch with a collar of scales, and there's a typical pattern on the back. So, would you reassure, encourage sun exposure, and say it will clear within 4 to 8 weeks? Start oral antifungal treatment as it's too extensive for topical applications. Ask history of sore throat, examine for lymph nodes, and examine for palmar lesions. Do a scraping for fungal studies and apply topical mometasone furoate to relieve itch for a couple of weeks. Refer to a dermatologist for skin biopsy. So what is the least appropriate action? Is it number 1, 2, 3, 4, 5? So I would, in this case, it is 2. But generally, I would say if you are not sure of the diagnosis, it's better to use antifungal than using a steroid. And never, ever a triple combination. It has no place in treatment of skin conditions, triple combinations. Now, the thing is, this is a case of pityriasis rosea. Classical presentation is this herald patch, followed by eruption that occurs with a Christmas tree pattern. Always we don't see this classic pattern. And then we may, even dermatologists will go and do a biopsy because it might, the differential is gutted psoriasis and also secondary syphilis. Secondary syphilis is rare, but then it's something you cannot miss. You can have palmar lesions, lymphadenopathy. And why not a fungal condition? Fungi, they will not come like a reactionary condition almost immediately. they almost within couple of days, they have to grow. So it's a slow process over weeks and months. But this is overnight, this happens. So this is pityriasis rosea. A 40-year-old lady with a history of atopy has been having rash on her abdomen for 1 year. It has not been responding to topical antifungals, but has symptomatic relief with topical hydrocortisone. What is the appropriate management? Use potent steroids such as clobetasol for an adequate length of time with emollients. Use a combination cream, gentamicin, betamethasone, miconazole. Use short course of oral steroids with topical antifungals. Do fungal studies, and if negative, check for compliance, adherence to use of topical steroid creams. So on topical steroids, see whether they're adhering. The antifungus is negative. Use oral antifungal creams for 4 to 6 weeks with soothing creams like menthol-based creams, and refer to a dermatologist if treatment fails. That's okay. So that's the correct one. Why? This is tinea incognito. You would expect to see a clearance in the center, but that doesn't happen when steroids are used. You do a fungal study, the yield or scales will be low and fungal studies will be negative. So that doesn't exclude a fungus. There's a epidemic of fungal infections that we see that are resistant to antifungals, oral antifungals, like grisoholmin almost never works. Terbinafine doesn't work. This is because of use of triple combination creams. It's seen in India and Sri Lanka. And so we need sometimes to use very long courses of antifungals. And so it's a time to, if it doesn't respond, to refer to a dermatologist. So we see these different, it may even look like psoriasis. This is a typical presentation. Discoid eczema you differentiate, because discoid eczema, there is no clear margin. It's something endogenous, something sitting on the skin from outside and growing. The extra, just beyond it's completely normal. This, okay. 25-year-old healthy man who complains of intense itch, which is exacerbated at night and not responds to topical medication presents to you. After examination, you diagnose him with scabies. What is the most appropriate treatment for this patient? Apply 5% permethrin cream on itchy areas twice daily until itch disappears. Apply potent topical steroids in combination with permethrin. Apply permethrin cream daily on itchy areas for 2 weeks, oral prednisolone in tapering dose. Refer to a dermatologist, start on oral ivermectin. Apply 5% permethrin on entire body below jawline, including genitals, overnight for 12 hours and repeat in 2 weeks. Yes, very good. The sad thing is we do see all the other ones like number 1, 2, 3 also happening, and which should not be so. So it's one application of 12 hours is sufficient, but if the hands or any area is washed, it should be reapplied immediately. And also fomites have to be treated, clothes have to be put in a bag and kept for about 1 week, because away from the body the mite cannot live for long, and all contacts have to be treated. So, okay. What is the inappropriate in the treatment? Use of salicylic acid 20%, wear well-ventilated shoes, topical fusidic acid cream application, oral erythromycin or topical erythromycin gel, avoid soaking feet for long. Which one is inappropriate? 1 or 2, 3, 4, 5. So if you have the diagnosis, it's clear this is pitted keratosis or Diametia. So this is not a corn or a wart, so you don't use salicylic acid. Everything else is appropriate for this. 10-year-old boy is brought to you with a patch of hair loss that developed over the last 6 months. Some home remedies has been tried with no success. What shouldn't you do in the management of this patient? Prescribe topical steroid and ask to come back in 1 month to consider intralesional triamcinolone. Do a swab for bacteria culture, ABST, do fungal studies, take detailed history on habits, topical application, ask patient to discreet, observe child for hair pulling, refer to a dermatologist for treatment. So the thing is, okay, is it number 1, 2, 3, 2? The thing that you should not do is number 1, thinking that this is alopecia areata. Alopecia areata can present like this, and sometimes due to home remedies, there can be a reaction and look like this. But if there's scaling, always think of tinea. Tinea can be boggy masses when it's a zoophilic, where there's so much inflammation. But it can be also very subtle like this, just scales and few broken hair. Dermoscopically will have more features. So it's very important to do fungal studies on the hair and the scrapings. And it can be of various lengths, which is hair pulling disorder or trichotillomania. It could be also alopecia areata, which can be multiple patches or single patches, but they'll have features for diagnosis like exclamation mark hairs and certain features under the dermoscopy. So if you're not sure, without treating with steroids, it's always better to refer or do fungal studies. A 25-year-old young lady who has been previously healthy with a strong family history of male pattern hair loss presents to you complaining of severe hair loss in last 2 months. She has also decreasing hair density over the last 5 years. What is appropriate in the approach to her management? Reassure her that this is due to COVID-19 infection that she had 4 months ago and does not require treatment. Doing TSH, full blood count, and ES are not indicated as she is previously healthy. 2% minoxidil topical solution is the best treatment approach at this stage. She shouldn't be referred for specialist assessment. She should be referred to specialist assessment to consider long-term anti-androgen therapy such as spironolactone, flutamide, and bicalutamide. In the absence of scarring alopecia, she does not require any specialist referral. So what is the most appropriate? Is it 1, 2, 3, 4, or 5? Now with COVID-19, we see a lot of patients coming with telogen effluvium. Telogen effluvium is, hair has 3 stages: anagen, telogen, catagen, and telogen. So the thing is, hair normally grow in the anagen phase, about 90% are in this phase, 8% will rest and 2% will drop. When you get ill, during that time, the body tries to conserve energy and shifts them into resting phase. All that is rested will drop off in about 2 to 3 months. So that's an increase. But she has also had an increase in hair loss over the preceding couple of years and a strong family history of pattern hair loss. So this is a time where we'll examine to see whether there are features of pattern hair loss which should be treated very proactively early to prevent hair loss in the future. So that's where it's important to refer for dermatology referral, because we will look at the hair follicles, see whether there are secondary follicle loss, and also think of giving anti-androgens. Now, TSH, full blood count, ESR is good to do because there may be subclinical hypothyroidism which is contributing to hair loss. A 5-year-old is brought to you with this papules of 1 to 3 millimeters size in the face, chest, limbs appearing over last 6 months. What is the least appropriate treatment in treatment of this child? Reassure, observe over next few months. Explain to patient that is infection and must be treated aggressively. Do cryotherapy under topical anesthesia. Let parents use keratolysis or phenol-based products at home. Curate or treat with topical TCA. What is the least appropriate? Is it 1, 2, 3, 4, or 5? Now, 2, it is infectious, but it's self-limiting. Body has to develop immunity and get rid of it. It will happen in 18 to 24 months. Now, if you treat it aggressively, what happens is that it's going to cause more scarring than it's going to help. And also, when you're treating these lesions that you can see, there are numerous other lesions that are not macroscopic. So basically, you cannot see them. So it's important, it's kind of to reassure the patient to reduce the load you may treat, but it's not, you don't need to treat it aggressively. 45-year-old lady with multiple comorbidities comes with this itchy papular rash on her limbs and torso for 2 months. What is the least appropriate statement? Drug that has been started 6 months is a possible cause. I have come to the end. Can I continue? I have about 4 other questions.
Go on, that's okay.
Sure, okay. Drugs that has been started in the last 6 months is possible cause of this. Presence of oral lesions and nail changes will help in the establish a drug as a cause. Potent topical steroids will help in the management. Referral to a dermatologist or biopsy is important. ACE inhibitors may cause this rash. Is it 1? That is the least appropriate statement. 2, 3, 4, or 5? So this is it's not very clear. It's a lichenoid eruption. That's this purple hue. They're like lichen planus. Lichen planus are papules that are polygonal, flat, plain, and purplish. And these can give this lichenoid eruption, can occur with certain drugs. And drugs, It can occur, especially like an eruption can occur weeks to months after taking the drug. So it's not immediate. Normally we think a drug eruption occurs almost within a couple of weeks, but this can be quite late. And it can be so for various other conditions also, especially with use of things like allopurinol, certain things with long half-lives. It can happen. Like for urticaria, it's quite fast. And there are various drugs that can cause, so in a rash that you are suspecting on a drug eruption, it's important to get an opinion if you are not sure, because there are various drugs that may be causing it. And normally the answer that was incorrect was presence of oral lesions and nail changes will help establish a drug as a cause. Generally, drug eruptions cause oral lesions. But in this case, oral lesions and nail changes are of the lichen planus as opposed to lichenoid eruptions. So in lichenoid eruptions, you don't get oral lesions and nail changes. What is the least appropriate step in your approach to a suspected drug eruption? Record all the drugs, including supplements that the patient was on the day the drug eruption started. Determine the reaction pattern, example, whether it's an urticarial rash or a lichenoid rash or a maculopapular pustular, erythema multiforme, Stevens-Johnson, TN type of rash, or eczematous. Determine the likely drug with a high reaction rate, known to cause such a rash out of the medication patient is on. So determine which drug may be causing it. Stop all likely agents. Start on oral steroids without delay. What is the least appropriate? Is it 1, 2, 3, 4, or 5? 5, yes. Steroids have no place now, not even in things like Stevens-Johnson. It's controversial whether they should be given short time. So generally steroids are not the thing other than in very, very selected occasions. So important thing is to record all, because you have to work backwards and see what is, because when there's a huge list of drugs, it's very difficult. As a general practitioner, when you are faced with a drug rash that you suspect, it's important to document all the medication and the durations when they were started and unto what time, so that it can be sorted out. From that list, we can choose which could be the one that is the culprit, one that has a strong reaction, a very high reaction rate, plus the one that has a temporal relationship to the rash that is basically likely to cause it. And also it's important to stop all likely agents. So those are 2 steps that are extremely important, and not to start on steroids. So it can be Stevens-Johnson, which can be quite serious, and all this can be prevented if the agent is identified early and stopped. This 2-year-old girl is brought to you with a high swinging fever with no identifiable cause for 5 days, with red eyes, red swollen lips, and maculopapular rash. What is incorrect? It is important to look for cervical lymphadenopathy. Examination of oral cavity is likely to demonstrate red palate, pharynx, and swollen red tongue. Fingers and toes are likely to be swollen and tender. Child is at risk of developing coronary artery aneurysms. Low dose aspirin is not a part of specialized management due to risk of hemorrhage. Is it 1, 2, 3, 4, or 5? Now, this is a case of Kawasaki's. It's very important to diagnose early, because around about 7 to 10 days, the child will go on to developing coronary artery changes and aneurysms and thrombosis, so it can be fatal as well. So aspirin has a place once it's diagnosed, low dose aspirin as well as IgG. So if there's high fever going beyond 4 to 5 days with 4 of the 5 of cervical lymphadenopathy, oral cavity changes, swollen red lips, fingers, that's erythema that starts on the fingertips and proceeds to the palms and swelling, we would have to diagnose this if there are about 4 out of these 5, and should act immediately. So when you see a child, I'm sure you are very good at managing children with fever, and in this circumstance where you are suspecting, it's very important to refer for specialist assessment, because early treatment is extremely important. That brings me to the conclusion. Thank you. Any questions?
Thank you, Dr. Arasinga. Are there any questions?
Yes, oral, it depends on what the eruption is. Localized eruptions, like a common localized eruption, is a fixed drug eruption. It comes on the same spot. Every time the drug is taken, a common thing is a lady may say, when I have menses, I get this patch, which is like, she may normally, they notice a darkening of a patch, but it starts with erythema, and there can be vesiculation, and then it can have post-inflammatory hyperpigmentation. So that is a fixed drug eruption because it comes on the same spot. It could be due to naproxen or even paracetamol that they're taking. So you can have localized. Some eruptions start localized and they can become generalized as you continue the drug. So it's possible, but generally most drugs, if your drug eruptions generally tend to be more generalized than localized.
Patients who come with recurrent urticarial reactions?
Yes.
Quite difficult in clinical practice to control.
Absolutely so. Yes. Now, urticaria is generally, we view it like this. Acute urticaria is very common. Almost all of us have got it during some time of our lives. So we get it as a reaction to a food, maybe a drug, and it disappears, doesn't come back. But if urticaria lasts more than 6 weeks, the tendency is that it will last for another 2 or 3 or 4 years. It becomes a chronic urticaria. It's an autoimmune condition. So we call it as chronic urticaria or chronic spontaneous urticaria. Most often they don't have causes. In fact, expert panels say you don't really need to go and investigate it either, unless you have specific features that warrant investigation. It's extremely difficult to treat. So what we would normally do is we go for the highest level of antihistamines that we can use that are non-sedative, which would be second generation antihistamines like desloratadine, loratadine, fexofenadine. And now we go up to the highest dose, which is higher than the dose that is recommended generally. Say fexofenadine 180, we can go up to 4 times that dose. And still, if it's not working, we can add something else. Practically, we add sedative ones, although it's not ideal because it's going to interfere with their life and driving and other risks. We can also now add certain other things like H2 blockers like ranitidine, sometimes maybe things like doxepine. Again, there are issues with it because it can cause QT prolongation, a lot of other issues. And if it's not working in chronic urticaria, we have to go for immunosuppressants. Commonly used immunosuppressants are cyclosporine. So basically, if there's not control, we normally they need to be seen by an immunologist or a dermatologist. We would go from there onto immunoglobulin. There's something called omalizumab. Sometimes we use omalizumab in combination with cyclosporine because currently I'm working at Sinclair Dermatology in Melbourne. It's like one of the biggest research institutes in Australia. So there we have patients who are on omalizumab and cyclosporine. Right? In Sri Lanka, to get omalizumab is, it's almost impossible. So most of my patients here I manage with cyclosporine when they are quite resistant to treatment. So it's a very difficult condition to treat, I agree. So sometimes it's a multidisciplinary team, like we manage with the immunologists ourselves, and ideally it should be with the GP as well. But sadly in Sri Lanka that doesn't happen because I of course normally write back to my GPs when they write to me. I have few young people who write to me. And so that should be the trend. But then again, with our busy practice where we see 50 patients in a couple of hours, I don't know whether it should, it's practical. But that close relationship is important to understand all this.
Right. Thank you, Dr. Arya Singh. Due to a lack of time, we'll have to close this session. We do have a token of appreciation for you. So if you would do the honors. And that brings day 2 to a conclusion. I would like to invite Dr. Pihan De Silva for the closing remarks.
Thank you, Sunit. I'm not going to take much of your time. Just a few words, just as a token of appreciation for the team behind the scene. I am really impressed to see this much of crowd till the end of the sessions. Actually, that's a highly enthusiastic crowd we had. It's a pleasure to see that. So I hope you had a productive weekend of academic knowledge and experience. So I want to add a few words towards this session, preparing for it. I hope everybody agrees that we had a very hard time country-wise, the situation, and it applied to us also. But with great difficulty, with the support of a very energetic team and the supervision and the guidance of the seniors of the college, we managed to pull this through. So all credit goes to the whole team, actually. Here, I would like to thank few parties, starting from the president himself, giving us all the guidance and support, and especially like the father of a house, taking care of all the money, providing the money, actually. We didn't have to do a thing about that department, and it offloaded a lot of burden from us. So thank you very much, sir, for that. And the rest of the committee, council members, thank you very much for all your assistance that you have provided. Then I would take the chance of thanking the resource personnel, chairpersons and the judges, and my steering committee. Special thanks goes to my secretary, Dineshani, and the members, and the scientific committee members led by Dr. Ruiz Hanifa and Dr. Gobit Ratnam, doing a splendid job. I would like to highlight Dr. Gobit Ratnam. He had overseen many areas other than his duty. So thank you very much, Gobit, and the team of the steering scientific committee. And another special thanks goes to Mr. Kamal and the team who have given us the multimedia support. Like last time, the virtual presentation, this time also he did a great job. And as usual, the college office. And last but not the least, the participants, actually. The GPs, full-time GPs, the part-time GPs, the people who are interested in general practice, and the well-wishers who appeared in numbers, actually. This is more than what we predicted. So thank you very much for your enthusiasm. Thank you very much for your commitment. I hope you carry on with that interest. We will also try to deliver up to your expectations. So thank you very much for attending this 47th college academic sessions of the general practitioners. Thank you. And I hope to see you in many more numbers in the 48th session. So we'll see you next time. Until then, take care, stay safe. One more thing, people who wish to be associated members, they can collect the applications from the front desk and bring into the college office. We will do the needful thereon. Thank you.